I want to thank everyone who stayed here for this session, anyone who did attend earlier, for giving your attention to lipedema. I think that we've heard a lot actually of new knowledge even in the past session from every single one of these panelists. So I'm really excited to have this session here this year. Thank you for attending. So I'm Rachelle Crescenzi. I'm going to present a perspective from in vivo imaging by MRI. I have no conflicts of interest to disclose. And so the clinical problem that our study is addressing is for the need for better differential diagnostics for lipedema. And as we heard from Dr. Stephen Dean's talk and our patient perspective from Sarah, lipedema is commonly misdiagnosed as obesity and lymphedema as well. We also do not have a sure etiology. We've seen some exciting things presented here today from the biology, but the true cause is still remaining unknown. And here's some numbers to the problem. Symptoms onset at puberty or pregnancy, but the average age of differential diagnosis isn't until 44 to 48 years of age, and that's a decades-long gap. We put a number about 20 or 22 years to that, and we'd like to see that number shrink. So we're really after that goal in our lab. So today's talk will address the need for objective tools to help a differential diagnosis of lipedema from obesity specifically. In my talk, I'll provide some latest findings of MRI to look at differences between lipedema and those with similar BMI that we will call the obese controls in terms of tissue sodium, adiposity in the arms and the legs. We'll look at leg vascular imaging, and we'll look at some neurovascular and sodium imaging profiles if we have time, and I'll summarize it with some lessons and opportunities. So I exist at Vanderbilt Medical Center. I'm also in the Imaging Institute at our medical center. So this is across the street from the main campus hospital. And it's a fully dedicated research institute to all modalities of radiology. Our lab is called the SALT Lab, and we have been collaborating across campus with clinicians from different disciplines since about 2016, with great support from the Lipedema Foundation. So we work with lymphedema therapists, radiologists, vascular medicine specialists, a biostatistician, and a good friend and mentor of mine in neuroimaging. And so we've been able to look at lipedema through the lens of a larger collaborative group. And I just want to acknowledge everyone's efforts and expertise here, because it did take a lot of early on, a lot of understanding from multiple disciplines. So we've arrived at a protocol that we think is useful to help look at and study and differentiate obesity from lipedema, and also lipedema from other types of lymphatic diseases like cancer-related lymphedema. I'll summarize some imaging findings from these various techniques, and these are techniques that we're pursuing in our lab, both in terms of future development of the technology and also applications here. So I'll cover today some fat-weighted whole-body MRI imaging, as well as water-weighted MRI imaging. We'll look at standardized sodium MRI, as well as non-tracer-based MR lymphangiography. And I'll start by talking about each of these methods and then the studies that we have used them in to look at lipedema. So we'll start with standardized sodium MRI. This technique requires some specialized hardware to receive and transmit the signal for 23NA, but it is in fact endogenous in the body and in high enough abundance that you can image it. So this is a non-invasive imaging method. As long as you have some of the hardware to do it, you can do it. And the way we apply this is in a standardized fashion. So below every extremity, here I'm showing the leg, we include bottles of saline with known concentration of sodium. This is just simple saline, NaCl, in water. And with these different bottles of known concentration, we can use the signal intensity in those bottles to calibrate the signal intensity that we see in the tissue. And in that way, we can calculate across the leg a tissue sodium content map. And it's standardized for everyone because we use the same bottles of sodium for every single participant. So this, we think, is really helpful to provide a quantitative, standardized tool that can be applied at multiple centers. We are very interested in multi-center trials, but this will be just a one-center trial today. Okay, the second method is fat and water-based MRI. This is a traditional anatomical imaging method, but we've tried to put some numbers to it, and there's various ways that you'll see this in the literature. In particular, we use these imaging methods shown here in the leg to identify regions of interest in the skin, in the muscle, and in the subcutaneous adipose tissue compartments, shown there in the colorized image. We've also taken an automated approach to this by pulling out all of the fat-weighted pixels and all of the water-weighted pixels. And when you put those together as a volumetric ratio, we call that the fat-to-water ratio, and it's really underlying that is the subcutaneous adipose tissue volume compared to primarily the water tissue volume or the muscle volume in legs with lipedema. They have relatively low IMAT or intermuscular adipose tissue. So that's the fat-to-water ratio. And in third, we look at a vascular imaging method that we're interested in how this relates to sodium and fat deposition in the legs. And this technique has been called MR lymphangiography, and we provide it in a non-invasive way. So this technique is really heavily T2 weighted and sensitive to slow-moving fluid in the tissue. You can see the example on the left is showing a whole leg view of lymphangiography in a patient with lipedema. You can see their fat deposition is sort of disproportionate from their abdomen to their waist. And in the MR lymphangiography view, we see these hyperintensities in the subcutaneous tissue in a also vascular-like morphology headed right into all of the lymph node clusters. So we think it's consistent with lymphatic anatomy. We also see non-specific imaging in the synovial fluid and in the bladder. That's just typical of a fluid-weighted technique. You can read more about those methods if you're interested. So now how do we apply these and how might it help us understand and differentiate lipedema? So I'll present one of our first studies looking at the hypothesis of whether patients with lipedema have higher tissue sodium and subcutaneous adipose tissue compared to women without lipedema who have a similar BMI. We enrolled patients with lipedema who met certain criteria, which I'll present next. And importantly, all of these participants did not have prior liposuction. They had a BMI less than 40. I apologize if that says greater. This is less than 40 because they had to be compatible with the MRI. And they had no other significant comorbidities affecting tissue sodium like chronic kidney disease, for instance. We performed the whole body imaging method that I described and standardized sodium MRI at a 3 Tesla clinical field strength exam. So in our studies, we've been employing this criteria for lipedema. We've acknowledged that all of our patients must meet the top criteria, and they must have at least 2 of the secondary criteria. And this was developed with lymphedema therapists, as well as the Genetics Center at St. George's, UK, who's been studying lymphatic diseases for quite a while, as well as in consult with Dr. Herbst at the time. So take it for what it is. That's our criteria. We also employ a staging method that Dr. Dean described, and this primarily describes the appearance of the skin and the amount of fat deposition in the legs. And importantly, it doesn't describe the amount of pain or other symptomatology like swelling. So we do think the staging is imperfect for lipedema, but nonetheless, we stage it. It more or less relates to the severity of fat deposition, and that's the only symptom there. Okay, so in our first study, we enrolled 14 controls. These are women without lipedema who have similar BMI, and 15 patients with lipedema. Overall in the group, they were matched for age and BMI. And I just want to point out that the lipedema cohort had quite a bit more pain assessed on the visual analog scale in their legs. And all of these other symptoms were with higher frequency. So these patients had easy bruising, swelling in affected areas in hot weather, fatigue, altered gait, a loose feeling of the skin or fat around the knee joint. The skin was cold to the touch in, say, 50% of these patients, and hypermobility of the joints in another 50% of these patients. So in this study in particular, we applied sodium MRI in the upper and lower extremities and the fat and water-weighted imaging in the upper and lower extremities. And we were really interested in capturing and quantifying that disproportionate amount and what is the molecular composition of the tissue. So I'll start by sharing some case examples and then the group level results from each of these methods. So first, the whole body fat-weighted imaging. I'm showing these examples in a healthy female and a patient with stage 1 lipedema who have similar BMI. If you observe, though, the amount of fat deposition, you might be able to appreciate they have a similar amount of fat in their waist and maybe in their hips. But as you scan down the legs, you can appreciate the greater amount of subcutaneous fat deposition shown in all of these white pixels here in the whole body fat imaging, all the way down throughout the extremity of the patient with stage 1 lipedema. This patient is only 23 years old, and already we see some differences. And if we quantify that, we've evaluated in this one case that the fat to water volume ratio is 3 times higher than the person with similar BMI as a healthy control. So that's a number and a case example. How about the group level results? When we quantify that fat to water volume ratio in the calf, it's significantly higher among our lipedema cohort compared to controls. It was not found to be significantly higher compared to controls in the forearms, but compared to within body, comparison in the lipedema patients, those red box plots are showing a differential of greater fat deposition in the lower extremity calf compared to their forearm upper extremity. So this data, we thought, tells us that there is indeed a disproportionate amount of that subcutaneous fat deposition among the extremities in lipedema, and it's also significantly distinct from controls with a similar BMI. So here's a case example of a more advanced patient with stage 3 lipedema in terms of staging. You can see the column on the left is this whole body fat-weighted view, and it may be more difficult there to appreciate the amount of fat deposition in the different segments of the body. So then we look at just in the middle panel, the forearms, and just at a slice in the calf on the far panel. In the top row, these are traditional water-weighted MRI images. In the middle row, these are fat-weighted MRI images, so the bright pixels now are in all the fat tissue. And in the bottom row, these are standardized tissue sodium content maps in the same exact slices. And what you may be able to appreciate is in the calf now, in the lower extremity again, in a patient with advanced lipedema, we see a greater deposition and volume of that subcutaneous adipose tissue space compared to this relatively BMI-matched control. This control has a BMI of 38.5, so these were both at the higher range of our inclusion criteria here. And then in terms of tissue sodium, while the upper extremity looks relatively similar amount of sodium deposition, there's quite a bit more in the lower extremity. And that range there is from 0 to 40 millimole per liter of tissue sodium. It's an average sodium across the intra and extracellular space. And we think this is in the physiologic range that we see across the lifespan in just healthy people. And here in lipedema, we see they're showing quite a bit more sodium in their skin and in the muscle, and in this case, in the subcutaneous tissue itself, more yellows and reds rather than those lower levels of sodium in the blue. So hopefully we've oriented ourselves now in the imaging, and I've shown you in a case example now, but what about the group results? So what we found in this study is that skin sodium and muscle sodium were significantly higher in the lower extremities of patients with lipedema compared to female controls with a similar BMI but without lipedema. That's a difference in their molecular composition of the tissue from this in vivo imaging method. And in the forearm, we found no differences among all of these 3 regions of interest. So we think that's a nice internal control region potentially. Again, it highlights the disproportionate amount of effect that's being shown in the legs with lipedema. So skin sodium has also shown in this study to relate to the amount of pain experienced in these patients' legs and also their clinical staging criteria. So that might be important to signify some severity of disease. But again, this is just a preliminary study, so just 15 patients there. Oh, sorry. If you're interested more in pain involvement in lipedema, I just want to point you to my collaborative study we did with Audrey Chakraborty and Joe Rakowski's lab, and this is presenting some nice data collected at the Fat Disorders Resource Society meetings where we meet patients and researchers and we all come together. So that was a pretty cool study. I wish I had time to go into it, but please take a look at it if you're interested in the pain, which again is this differential symptom from obesity, and what we can say more about that. I also want to highlight some interesting work that my first graduate student did in the lab, and she looked at the whole leg data sets that we had and provided an automated tool to look at the SAT volume and the muscle volume in all of these slices. And when she did that among this same cohort, she found that in every single slice, there was a significantly higher SAT deposition in our patients with lipedema compared to controls. In the thigh in particular, we found the largest effect size of that differential fat. So I just want to point out, if you're looking for the region of best diagnostic and differential from obesity, we would suggest, our data suggests at least, it's in this upper thigh region here, kind of following this contour of a cartoon leg. Okay, but again, it was significantly higher in all segments of the leg, and the muscle volume did not differ, at least in our data set here. So the muscle involvement in lipedema is still out, and we would love to know more about the muscle effects. Okay, so then just to summarize some of these initial findings of tissue composition by MRI, we've shown that leg tissue sodium and fat deposition are significantly higher in patients with lipedema compared to these well-matched controls with a similar BMI. Again, everybody lower than a BMI of 40 here. So we're not looking at upper obesity classes. Everyone was compatible with the MRI. The tissue sodium and fat were also significantly elevated in the legs and not in the forearms. And in other studies with bioimpedance, we found a similar and consistent result that higher extracellular water deposition was local to the legs in lipedema compared to their arms and higher compared to controls in stage 1 patients. So why are we seeing these features, and what kind of mechanism might this point us to? If if the fat is not just larger, but it's also salty, what is the mechanism that might be regulating that salt? And is there something outside of the metabolic system that's regulating it? So I would point us here to this nice review paper looking at skin sodium and how it is deposited and stored in the skin when there's a higher amount of connective tissue species like glycosaminoglycans. Those are negatively charged species, and they act as a sink for positively charged sodium. So that's one piece to keep in mind in our biochemistry. The other part is vascular regulation of tissue sodium. So when there's high levels of sodium, the body likes to really regulate that well and get it out of the tissue. So the body will stimulate lymphangiogenesis and also vasodilation to try to control amounts of sodium. So this is all preclinical literature, and we would love to know if any of that plays out in the human case. So that's kind of why we started developing this MR lymphangiography technique. So I'll take you through one study here and some of our findings on MR lymphangiography along with tissue sodium and fat in the same cohort. So in this case, we were enrolling more patients with lipedema. We had a total of 4 different cohorts we were able to look at. We enrolled patients who were the healthy female controls with a similar BMI, patients with lipedema, a second cohort of patients with lipedema who also met criteria for lymphedema. They had those clinical criteria for swelling that doesn't resolve at night, for instance, or fibrotic tissue texture with pitting edema. So that was a separate cohort we brought out in this study. And finally, a cohort as a positive control, really, who had cancer-related leg lymphedema, where we knew the source of lymphatic involvement. Among these patients, among these cohorts, the lipedema patients had the highest amount of pain. And here's a bit of our method. So we asked 3 radiologists to join us. They performed a blinded review in all these cases. And how they broke down their review was like this. They looked at the axial source images, all in the lower extremities in the calf region in particular. The axial images, they scored whether they saw these hyperintense features. They called those extravascular on this view only. And they scored 1 if the person had real focal hyperintensities, or gave them a score of diffuse, and that would have been marked by a 1, kind of a yes or no score. And then on the coronal view, where you can see the hyperintensities that relate and trace through slice, those were vascular features, and they scored those as either linear or dilated. Again, this was in a blinded review. So first I'll take you through 4 case examples here as briefly as I can, and then the group level results. So this is looking on the top row at a patient with lipedema who also had lymphedema, and compared on the bottom row to a patient with our positive control, definite lymphatic involvement, cancer-related lymphedema. I'm choosing these 2 examples first because they're our most involved cases in terms of their lymphatics. They both had clinical symptoms of lymphedema as well. And so we're focusing just on hyperintensities in the subcutaneous region. The patient with lipedema and lymphedema had diffuse hyperintensities in the extravascular space and vasculature that was noted to be dilated throughout that lower extremity in the calf. This is compared to leg lymphedema with cancer etiology and cancer treatment etiology. They had more focal extravascular features just in the anterior leg and dilated hyperintensities throughout the leg. So definite edema in both cases is what our radiologists would say. Next, that same patient with lipedema with lymphedema, now compared to a patient just with lipedema alone. You can see in both cases they had diffuse hyperintensities in their extravascular features of the leg. And in terms of the vascular morphology, they were dilated in the case with lymphedema and more linear or just conspicuous in the case of lipedema alone. And that was focusing specifically in the subcutaneous region, not looking at the muscle vasculature at all in this case. Okay, so now these are 2 cases with a BMI greater than 30, so would technically be classed with obesity. Here, our patient with lipedema has those diffuse features, and compared to the female controls in this study, those female controls had relatively not apparent hyperintensities, despite also having an obese BMI. So we don't think this is just an effect of obesity. We think this is particular to lipedema, and we need to understand this further. In the lipedema cases as well, we see these conspicuous linear vasculature. Finally, these are 2 cases with BMI less than 30, so maybe considered our least involved cases. And we still see in this early patient with stage 1 lipedema evidence of focal hyperintensity starting in that subcutaneous space. So we are interested in following up with this contrast mechanism further and how this might relate to disease in terms of sodium and fat. But I'll just show now the group level results there. I'll take you through the summary here. We're looking at a proportion or amount of those features among each of those 4 cohorts. You can see that the cohorts with lipedema and those with lipedema with lymphedema had a very similar proportion of features, despite one having clinical symptomatology of lymphedema. So no distinction really between their MR lymphangiography features, so that was kind of an unexpected finding there. And the patients with, also diffuse and linear features were noted most frequently in lipedema or most differentially. And these patterns we think are consistent with subcutaneous adipose tissue edema and full lymph vasculature that makes them either linear and conspicuous or dilated. And that is true whether our cases had lipedema with or without lymphedema. Thanks so much for listening to my story there. Do I have time for the neurovascular? It's 4 o'clock now. Would you like me to wrap up?
I think if you can give us 90 seconds of neurovascular, that would be fantastic.
Okay, great. Let's do 90 seconds. So more than, this is just showing their disproportionate pain, swelling, and fat. The point here is that they have chronic pain as well. And we were wondering, in these patients, might they have that report pain, fatigue, and psychological distress? Might there be some differences in their cerebral physiology that we are missing if we just look at the fat deposition symptom? Okay, so in these patients, we did some neuroimaging studies. We found no difference in terms of common anatomical features, no difference in their large vessel features in the brain or tissue volume. We also found no differences in cerebral sodium by a similar standardized protocol. We looked at it because we could, didn't find any difference there. That was at 3 Tesla MRI. And finally, we did see, on average in the group, a higher level of cerebral blood flow in patients with lipedema compared to our BMI matched controls. I should note that this range of higher CBF, or cerebral blood flow, was not out of the range of normal. So there was no clinical indication there. But I do think it's interesting to relate that back to their features of pain and chronic pain as well. Might their body be reacting to that experience of pain that's day in and day out? And to this community, I came to TOS in Nashville, where I'm from, and I loved hearing about the gut-brain axis. So if you're interested in applying some neuroimaging techniques in these patients, especially related to pain, I would love to see this be used and further studied. If you could help me identify in the cerebrum what's going on, it'd be pretty cool. So I just throw that out there for that reason. Finally, I just want to summarize the lessons that we've learned were published in Obesity, the journal of this society, and I really want to thank that journal for taking up the cause of lipedema in the literature and letting us publish in your home for a little while. So hopefully you've read these papers. Keep publishing there in Obesity, I think. And some opportunities here are for the trainees and researchers to come and meet patients and meet the lipedema community at our FDRS Society meeting. It's in St. Louis this year in April. Also, keep pursuing funding. The Lipedema Foundation supported me throughout my early career. I've gotten foundation funding since the start of my postdoc and now have NIH funding, and that was because of the Lipedema Foundation's great support. So don't lose sight of the excellent foundations that can help support your research. We now have a nationally funded clinical trial we're super excited about and thankful to the NIH for their support. And we hope to be developing now a biorepository that will go alongside with this deep imaging phenotyping. And we hope this is a resource to the community. So I really do welcome collaborators, postdocs, any investigators who want to work with this resource. We hope to keep growing it. Thank you guys so much. And we'd like to